So this is a research study, a randomized controlled trial that's been going on for about 5 years. It was funded by Centers for Medicare and Medicaid Services, CMS, and it was a 5-year grant. And the first 4 years we spent working with women, low-income women on Medicaid who were smokers during their pregnancy, and then we followed them throughout postpartum. So that was the first 4 years. The last year, we've been working on this impact evaluation, basically looking at the data from all different angles, looking for themes, reflecting back with our team, talking with the women that were in the study, and trying to figure out the big question is how we can help low-income women quit smoking. So here's kind of the agenda for the day. I'll be with you for about an hour, right up until lunch. We are going to look at 2 different data sets. We'll look at qualitative and quantitative. I promise we're not going back to nursing school or grad school or college. We'll try to make this as interesting as humanly possible, as numbers can be. If you are a numbers person, close to my heart, we will have all of the data available to you, the full analysis, in a report later on this year. We'll also have a shortened version, so if you want kind of the quick and easy way to digest the information, we'll make sure to get that to you too. But we'll go through everything today in person, so if you have questions, feel free to stop me, like, I have no idea what you're talking about, that's fine. I won't be offended. So we'll have our 2 different data sources, and then we're going to put it all together and talk about, from our perspective, kind of how we've analyzed the data, how we've interpreted in our recommendations for future programming. And then I'm going to ask you to weigh in, because we're kind of at the beginning stages of this. It was a ton of data. The results are really interesting and not at all what we expected. So we want to know what you all think as well. So we'll do an activity towards the end where you can kind of weigh in and share your thoughts and your interpretation. Does that sound good to everybody? Okay. So first, a little bit of a background. For those of you that know a lot about striving to quit, this will be a refresher for you. For those that are new, this will be a good background. So CMS, the Office of Innovation, they gave away this grant, this research grant money to 10 different states, and Wisconsin was one of those. And basically their goal was to see if financial incentives would help Medicaid members to change their behavior. So some states looked at diabetes management and adherence to treatment. Some looked at obesity. Quite a few states looked at tobacco. And really looking at the impact, or just that role of financial incentives. Did that change people's health behaviors or health outcomes? And the theory is contingency management. Has anyone heard of that before? So yeah, it's been used a lot in substance abuse. It's been used sort of in anti-poverty, and it's now just kind of making its way to public health. So this was the Federal Medicaid's office way of kind of trying this out to see what happened. So Wisconsin was one of the 10 states. We focused just on tobacco, and then there were 2 arms of the study. So the tobacco quit line, which I'm sure everyone is familiar with, hopefully, yes, okay. They worked with adult Medicaid members, and then on our side, we worked with the pregnant and postpartum members through First Breath. All in all, we had about 3,000 Medicaid members in Wisconsin participate. 2,000 were with Quitline and about 1,000 with us. So why did we focus on Medicaid? That's a question that needs to go before all of this, I think. I'm sure most of you know that prenatal smoking rates in Wisconsin exceed the national average by quite a bit. We also know, looking at 2014 birth certificate data, which just became available, that about 9,000 babies were born to Wisconsin mothers who smoked in 2014, and 70% were on Badger Care. That's a huge burden on Medicaid, and also a disparity that we're not okay with, the state's not okay with, and Medicaid's not okay with too. If you take a look at a wider lens and you just look at prenatal smoking disparities in general, so if you look at all pregnant women who are in Badger Care, 1 in 4 smoke. If you look at all women on private insurance, 1 in 17 smoke. Like, that is huge. That is astronomical disparity. So that was really our goal, was to find out how can we do this better? We need to do a better job for many, many different reasons. Yeah?
I'm sorry, quick question. That 13% versus is the 9% the national average?
Yes. Yes, exactly. Yep. So yeah, Wisconsin is about 13, national average is 9. And it's gone down over the years, but it's stayed at 13% for probably the last, I don't know, close to a decade. So we haven't really been able to move the needle much. And we can see that the burden of that is right here. Okay, so what did this striving to quit intervention, what did it really look like? What did we do with these 1,052 women? So the first thing was they did first breath with all of you. So they had to be in first breath in order to get into the study. So they did first breath prenatally, and then after they delivered, then our striving to quit health educators, who were employees of the Health Foundation, worked with them in the postpartum. So Teal, Hattie, Felicia, and then all these other ladies up here. They went into the participants' homes, they did phone counseling, and basically an intensive intervention. So what you do in first breath is brief intervention, right? You have your 3 to 5 minutes, at least 3 times, and that's in addition to all of the other things that you're already talking with them about as part of your care. What we did was just tobacco. And of course we talked about other things because you can't talk about tobacco without talking about triggers and stress and all of that, but really the program was focused on just tobacco cessation and then also relapse prevention. Because what the studies show us, the literature shows us, is that for women that quit during pregnancy, most of them will relapse by 6 months or 1 year postpartum. The studies are kind of all over. It's like 60 to 85% is what the literature shows us. So we know that that's a huge issue too, and we want to work towards long-term change. You don't want the same women coming back smoking every single pregnancy, which I'm sure you see. They're enrolling in first breath a second time, a third time, a sixth time, and we want to try to stop that cycle and move more towards long-term change. The other thing they got as part of this striving to quit intervention was carbon monoxide breath tests. Has anyone seen one of these before or heard of them? Okay, yes, of course. And basically it looks like a breathalyzer. And we had our participants blow into this and it gave a reading of carbon monoxide, which is an indicator of smoking status. And we used that as pretty much our way of showing her smoking status without just having to ask, do you smoke, yes or no? Because I can tell you whatever they want. And everyone has a different definition of what it means to be a smoker. So we wanted some hard data, and so that's what we used. And then the other thing, of course, was gift cards, because we were looking at the impact of financial incentives. Any questions about that? Okay. So again, here's the carbon monoxide breath test. We actually have new machines in the back, Hattie and Felicia, so if you want to see one in action, we can do it on each other. I won't have you do it. I mean, I will volunteer myself to do it. And you can see the different results here. So 0 to 6 parts per million, they were a non-smoker. We had that kind of upper range because if someone's exposed to a lot of secondhand smoke, they can register in that upper register. So we had, systems in place. If they said, no, I haven't smoked at all, but they were still showing up as a smoker, we would have a backup test for them. All the way up to very heavy smoker, and we did get a lot of those. Pack a day, 2 packs a day. And then when we calculated our quit rate, so in a minute I'll kind of go into the results, that was all based on this. If they passed, if they were 0 to 6 parts per million, they failed. We don't want to say fail, but they were a smoker if they were more than 7. Does that make sense? Okay. All right, so the results. First, I'm just going to show you quit rate. So this is based on the carbon monoxide breath test at 6 months. So they had the intervention for 6 months. We took the carbon monoxide on that last visit, and 39%, almost 40% were smoke-free at 6 months. To put that into perspective, looking at the clinical practice guidelines, which is basically, I'm sure a lot of you have heard of it, it's like a meta-analysis of thousands of tobacco studies. So we can see, to put it into perspective, a typical low-intensity intervention, and this is not pregnant or postpartum women, this is just the general population, low intensity, you can expect about 19% quit rate. For other intensive interventions, up to 300 minutes, 29% for non-pregnant and non-postpartum. And for us, we were 39%, so we were pretty pleased with those results. The other thing is that the number of sessions they completed correlated with their success. So those that completed 8 to 10 sessions, their quit rate was actually 45%. And again, looking at typical intensive intervention, and this is just based on session, not minutes, you'd look at 25%. So that is quit rate by session. And then postpartum relapse, and that was the other goal. We wanted women to quit, but we also wanted women to remain smoke-free. So our relapse rate was 27%. So of those women that quit smoking during pregnancy, only 27% were smoking again by 6 months. And we have a really nice comparison to this, which is PRAM's data set. Everyone familiar with PRAM's? Yes, of course. I don't need to ask you that. In Wisconsin, looking at the 2012-2013 data set, and just for Medicaid, it was about 45%. So what this suggests is that this intervention is pretty good at relapse prevention. Another just marker for you to look at, the Healthy People 2020 goal for postpartum relapse was 38%. So we were very, very pleased with these results as well. All right, so the main goal was financial incentives, right? Everyone in the study, all 1,000 women, got the same intervention. They all got the same number of home visits, the same treatment from our health educators. What was different was how much gift cards they got. So those in the treatment group, they got up to $500. So they got a gift card every time they did a counseling session. If they did a CO test and they passed it, they got an extra gift card. And the controls got still $160. So nothing to blink an eye at, but $500. That's pretty good. The average participant got $250. So we had very few women that actually got up to $500. Most were in this range. And then the treatment quit rates were about 1.5 times out of control. So the women who got the more gift cards, their quit rates were about 1.5 times that control. So we thought that was interesting. Our research partner said that this is modest. And I was just on a conference call just last month with the other 10 states, and they all had pretty similar results where there was just a little bit of a benefit or no benefit at all for those in the treatment. So that was really surprising to us. And the other thing I guess we've been talking about all along is that we thought there was something else there, that maybe it was the expanded services, that had some sort of influence too. And that's what we really wanted to look at in this impact evaluation, was that if this was modest, how did we get those results? So that's one piece of the pie. We wanted to see what else was in that pie that might have impacted the results. Does that make sense? Okay. So beyond the incentives, we did this year-long impact evaluation. We had those two different data sources that I was talking about a little bit before. The first is we looked at the non-incentive factors that could have affected smoking outcomes. So we had 30 different categories and 100 different factors that we looked at to see what else would pop up, what else was as strong as gift cards or stronger in terms of impacting outcomes. The second one was we could speculate all day and run all these tests, but we could just ask the people that were in the study. So we did this qualitative sub-study where we took our participant graduates, we pulled them back, and we asked them a bunch of questions as part of focus groups. And then we wanted to take those and kind of put them together because the results were not exactly what we expected. So we're in the process of doing that right now, and we also want to hear from you at the end. Okay, so we'll start here with quantitative. So again, we had over 1,000 women. What we did was we took their files. They had case notes. We had surveys. We had quit smoking action plans. We took all of that and we put it into a database. And then we looked for group differences based on their post-intervention smoking outcomes. So we had about 700 women that did that 6-month test. So we looked at group differences. So for example, did younger women quit at higher rates than older women, or vice versa? Or did women with really good social support networks, did they do better than women with small social support networks? So those are the things we looked at for about 100 different factors. So I'm going to see if you can guess what the results were, because we were a little bit surprised. And we'll start with the age example. So do you think that age impacted smoking outcomes, their ability to quit? Yes or no? Just shout it out.
Yes.
Yes. Everyone thinks yes. Okay. You are right. Age did impact smoking outcomes. Do you think the younger women or the older women did better? Oh, a lot of older. Oh, and then the youngers. Okay. It's actually both. This one was really interesting. Women who were in their late, like 18 to 25, they had the best quit rates. They were at about 42, 43%, keeping in mind the average was about 39. So they did much better than average. And then women in their late 20s and early 30s, they did not do so good. They were much lower than the average. And then the older women, 36 up to 40, I think late 40s, they had much better. They were about average and a little bit higher. Looking at race, and I just want to put a caveat here that we had about 45% were African American, about 45% were white, and then we had American Indian, we had Latina, we had Asian women, but the groups were not big enough to actually do the tests. So for this one, we're just looking at African American and white. Do you think that race impacted smoking outcomes? No? Yes? No? Or divided? Nope, it didn't. They were exactly the same. How about, oops, oh, I gave it away. Darn. Too excited with my button. Educational attainment was one we were really surprised by. I don't know how many of you listened to the webinar we did this spring with Karen Palmersheim. She's the one who looks at, she's a scientist, and she looks at all the birth certificate data, just looking at smoking for the past 25 years. And educational attainment was one of the strongest predictors of prenatal smoking prevalence. Women with high school or less, they smoked 10 times that of women with college. For whatever reason, in this intervention with this group of women, it did not impact at all. And we looked at all the different groups. The only group that was not big enough was grad school or post-college. That group was not big enough to run them, but everyone else was, and that was not, yeah, so that was interesting. How about relationship status? Yes. Everyone says yes. Nope, it didn't. Don't know. And for first breath data, it does. You know, we looked at the 10 years, and that was a pretty strong indicator. For this group of women, nope. Employment status, yes or no?
I'm not going to tell you.
Yes. It did. So who did better, employed or unemployed? It was unemployed. Yes, I know, and this one kind of shocked me at first. I know. Upon further reflection, we think, she's going back to work. Maybe there's other coworkers that smoke breaks, the added stress of trying to figure out how to get to work, childcare. I have 3 kids under 6, so childcare is a big stressor, I think, no matter where you are in your life. So we thought that was interesting too. In fact, I was in Eau Claire 2 weeks ago we have a health educator in Eau Claire. We were out on a home visit, and the woman was 39 weeks pregnant. Like, she was ready to go. She could not even get off the couch. But she said the only time that she smokes is when she's at work. She works in a nursing home, and part of her job is to wheel the residents out to take their smoke break. So she wheels them out, they take their smoke break, and she does too, and that's the only time she smokes. So there was a perfect example of employment status not really helping the cause. How about other smokers in the home? Yes, very, very strong indicator of smoking success was other smokers in the home. All right. So the takeaway here is that we can't control these factors. We may want to, but we can't control these, but they're still important to consider when you're developing your quit plan. If you have those younger women, they might be more receptive to the intervention. They might have not been smoking as long, so maybe they're a little bit easier to deal with. Not all of them, but maybe generally speaking. And also looking at maybe your older women. Maybe they've tried multiple times. They've been around the block. Like, let's use that experience to their benefit. So I think they're important to address and important to consider when developing a quit plan. All right, looking at psychosocial characteristics. Did the number of people in her social support network impact smoking outcomes?
Yes.
Yes. Anyone else? It didn't. No. I don't know why. We were really surprised by this. How about breastfeeding attempt?
Yes.
You're saying no. In the back, they're like, no. It didn't. No. And we had to really think about this one. For a lot of the women in the study, we tracked this too. I just don't have the numbers right now. Not everyone initiated breastfeeding, and for those that did, the duration seemed to be a lot lower than we thought it was. So if you have a woman who breastfeeds for 2, 3, 4 weeks, or maybe 6 weeks, this test is done at 6 months. So maybe it was a protective factor those first couple of weeks, but by 6 months, it's no longer. And maybe for those that did, but it wasn't the majority. How about number of stressors? Yes, very, very clear correlation. The more major life stressors that she reported to us, the lower the quit rate. And then type of stressor was one that we wanted to look at. So we asked all of our participants to name their major life stressors. So over the course of 6 months, they would check these certain things. So these are self-report. And here's some of the top ones that we looked at. Domestic violence, financial insecurity, substance use or abuse, homelessness, transiency, mental health diagnosis, legal issues, job problems, difficulty caring for multiple children, death or major illness in the family. So which of these, so what we did was, I should explain this first. We looked at women who checked domestic violence versus those that didn't. Does that make sense? Those that looked at checked financial security, those that didn't, to see if there was any differences. So what do you think? Which ones were where they impacted the quit smoking outcomes? Mental health, homelessness, substance use. Someone said all of them. Okay, you ready for the answer? Just those two. I had to really sit with this one for a long time. I called Teal right away, like, this doesn't make sense. Help me figure this out. And I think the conclusion we came to was that, well, two different things. We were looking at one stressor versus not, so that was different. When you add them together, certainly it really affects quit smoking rates, but looking at them singularly, they don't. So for example, substance use, it was about 50-50, which we were like, that just doesn't make sense. But I think and I'm sure a lot of you have this sentiment too, like if a woman is dealing with all of this stuff, like is smoking really the priority? Should we be spending our time on smoking? And I think for, going back to this one, for half of them, yes, they have too much going on. They're not going to quit smoking. But the other half did. They can and do quit smoking despite some of these major life issues. So we've been really kind of wrestling with this and thinking that we need to kind of change the narrative when it comes to major life stressors and other things in her life. Like, she can still quit smoking despite all of these things. And that surviving some of this, getting through, you're learning coping skills, you're learning how to survive. That might translate into a quit smoking attempt. And vice versa, if you have all this going on and you really do want to quit and you're able to, that those skills can translate to other areas of your life too. So Teal's going to talk about this later in the more application part of this session, but I just thought that this is so interesting and something we, in our programming, are really starting to think about too, and kind of how we talk about stressors. All right, our next section here is looking at smoking history and status. So age started smoking, so the age they started smoking, do you think that impacted quit smoking outcomes? It actually didn't. However, we didn't look at number of years of smoking. So that's kind of our next step. That I know for First Breath that was a big one, was number of years smoking, and that's kind of an indicator of nicotine dependence. How about max smoking amount? So the question we asked them was, during the period in your life when you smoked the most, and they would give an answer. Was it half a pack, 2 packs? Did that impact quit smoking outcome? Yes, definitely. How about smoking status at delivery? Yes. How about smoking amount? So light smoker versus heavy smoker? No. It did. And what this suggests to me, and I'd love to hear if you have other ideas, is that this is indicative of nicotine dependence. Right? Yeah, it's like the light smokers did much better than the heavier smokers. And it might be the dependence, but it also just might be their lifestyle, right? How it fits into their daily life, their habits. They're used to smoking every hour. Then that's different than someone who's smoking a half cigarette every other day, right? So nicotine dependence, important consideration. How about their attitudes? We look at quit importance and quit confidence. How important is quitting to you? How confident are you in your ability to quit? Do you think either of those two impacted? Yes. And that was a really clear correlation too. The more confident, the more important it is to you, the more likely you're going to follow through. Another question we asked was, what is your reason for wanting to quit? Do you think the type of reason that they listed impacted their outcomes? It didn't. We were surprised by that one too. But upon further reflection, like looking at the question, if they were able to pick a reason, any reason, that might have been enough, right? Like the type of reason doesn't matter. A lot said, for my baby, for my own health, money, someone else wanted me to, but having any reason probably sets you up on the right path for sure. How about smoking triggers? So the things in their life that make them want to smoke. Yes. How about the perceived barriers to quitting? What are their main barriers? What do you think? Yes. So these two were interesting, and they kind of fit in the same model. The women who said things like, everyone around me smokes, I smoke socially, those women did actually a little bit better than the average. Women who said that they smoked to avoid withdrawal, those women did not do as good. So it kind of goes back to what we were talking about before, that the nicotine dependence, that seemed to be a really strong negative influence on smoking. Whereas the social piece was not really as strong as we thought it was going to be. So the takeaway here is attitudes and perceptions, they have a huge influence on outcomes. All right, the last set we're going to look at here before we move on is their quitting behavior, so the kinds of things that they did to try to quit. How about type of coping skill? So that might be, did they chew on regular gum? Did they distract themselves by playing on their phone? Did they do deep breathing? Do you think the type of skill they used influenced? Say no, no? Yeah. A couple yeses. It didn't. Did the number of coping skills they had at baseline, so at delivery, did the number of skills they had influence? Yes. That was a really strong indicator too. So to me, this is one of the key ones because we measured this after delivery, so after you all had been working with them. So if they had coping skills that they learned through First Breath, that set them on the path to have better quit rates. And then we looked at the number of new coping skills acquired. So by the time they enrolled in Striving to Quit, till that 6 months, if they learned new coping skills. Do you think that impacted? Yes, it definitely did. I hope so.
I hope so too.
Yeah. And actually, we looked at if they had one, if they had 2 or 3, 4 or 5, but the biggest jump was just from 0 to 1. So if they learned one new coping skill, that greatly increased their chances of being able to quit. So we thought that was pretty interesting. And I won't spend a lot of time on that because that's like half of Teal's presentation. And we're going to talk about how can you as providers, how can you increase the number of coping skills or kind of the tools in the toolbox that she has. So the takeaway, helping a woman discover new coping skills can be one of the keys to her success. Okay, before we jump into this, any questions or last thoughts about the quantitative data that I shared here? Again, if you're a numbers person, we'll get you all the p-values. Don't worry, I'll share all of that with you later. If not, we'll move on to part 2. So this is the other side of the data. This is the qualitative, where we thought, we could speculate all day as to why younger women, why older women, or we could just go straight to the source and find out what our participants thought. So we got approval from the IRB and from our funder to do these focus groups. So we took women that had already completed the study, and we pulled them together into small focus groups to have a discussion and see kind of what they thought. These are some of the participants from one of our Milwaukee groups. We had 4 Milwaukee groups. So we did focus groups. We also did in-depth interviews. We had some women in really rural areas that could not travel to one of our cities in Wisconsin to do these. So we did in-depth interviews over the phone too if they couldn't come, or if they didn't have transportation, or they didn't want to talk in a group setting, which would be fine. So we had this interview guide that we used with everyone. We asked them about perinatal smoking attitudes and perceptions, their reaction to First Breath, their reaction to Striving to Quit, and then what recommendations they had to better serve pregnant and postpartum smokers. We had 143 women participate, about half did a focus group, and we did 12 groups throughout the state, and the other half did a phone interview. So here's what we found. We transcribed every focus group, and we put them into this system, we coded them, and then we looked for the top themes that emerged. Number 1 was stress. No surprise. They listed their top stressors. It was the number 1 root cause for prenatal smoking. It was the number 1 reason for postpartum relapse. And there was a lot of talk about smoking as a stress management tool. And I think Chelsea alluded to this earlier. It's a pretty darn good way, it's easy. It's something you know how to do. You don't have to think about it. You don't really have to plan for it. And it feels good. So it is kind of the go-to for a lot of women that don't have a lot of other coping skills or ways to deal with their stress. And also mood came up a lot too. Fear, anxiety, depression, all of these things. This quote I thought was so interesting. I wasn't ready for him to come. I'm 18, I'm scared, I'm alone. My water broke and I'm walking around the neighborhood looking for a cigarette, dripping water. I literally smoked up the stairs to the hospital. Smoking was all I had. And that sentiment is something we heard a lot with smoking. That was all I had. That's the only thing that kept me sane through all the craziness of life. The other thing that came up, the number 2 thing that came up was social support network and social environment, kind of the influence it had on their smoking attempt. The majority of the responses said that their social support network, their friends, their family, their significant other, father of the baby, they had a negative influence on their ability to quit. There was a few exceptions. Some did say that they had a positive influence. Their partner was really supportive. Their mom quit with them. Their friends helped them out. But overwhelmingly, it was negative. They also talked a lot about household smoking, especially families that were, had intergenerational households where it's mom, baby, grandma. If you had 5 other adults all smoking in the house, it made it really, really hard for them to quit and to negotiate any ground rules about not smoking around them or not smoking around the baby. So that came up a lot. Some groups, and not all, also talked about it being socially acceptable, that no one thought anything to see them pregnant and smoking, that they didn't feel that that pressure was there. This last quote here I think was so poignant. I was shamed more for not breastfeeding than for smoking. The last thing that came up when we asked, what do you want? What can we do to help low-income pregnant and postpartum women quit? There was a positive reaction to those expanded services. We talked about First Breath too. I'm not going to talk about that as part of this session, but at statewide meeting next year, we'll share those results. But since we're just talking about striving to quit, the role of the health educator was most impactful. And we asked, like, what do you need? We thought they'd say gift cards or, things that would make it, easier to participate. But they desired intensive, in-depth smoking cessation intervention, and they had a desire for one-on-one, long-term, trusting relationship with a smoking cessation counselor. Those were the top 2 things that came up in all of the different groups. And this quote, I think, also really sums it up. She, the health educator, would help me try and figure out what is happening in my brain. What are my talents? What are my coping skills? She, delved into my brain. She was almost like a mirror to me. She was very special to me. I thought, that's pretty powerful right there. All right, so now we're going to figure out how to put this together. We had the qualitative, the quantitative. How do we take this massive amount of information, and what do we do with it? So this was the method to our madness. I won't spend a ton of time on this, but what we did was we took, remember all those factors from the beginning, if they had the stop sign or the star? We took the ones with the stop sign and we put them here. Low statistical significance. The ones with the stars, high statistical significance. Then we took from the focus groups, we had all of the, we transcribed it and coded it and all of that. The things that came up a lot, we considered to be high perceived importance. The things that didn't come up very often or not at all, low perceived importance. So we kind of grouped them together. Does that make sense? Mm-hmm. So in this category, low and low were race, educational attainment, and a couple of other things. And we're not saying we're not going to focus on that, we're not going to talk about it, because I think those are very important and real issues. But we are going to focus more on here first for our immediate next steps. Does that make sense? Okay. So low statistical significance, high perceived importance. Perception is reality. So even though the numbers didn't show what maybe we thought it was going to, the things that the women said, yes, this really matters to me, those are the things that we want to focus on. The stress management, the types of stress, the role of friends and family, the social support piece is definitely high perceived importance, so something that we're going to focus on. Also, the things that were low in perceived importance, they weren't talked about much in the focus groups. We'll still focus on those too, and we just want to look more in depth and maybe do more studies, because this, all the things that I've shared with you today, they can't be generalized broadly. This is just for this group of women. So they're things that we want to continue to explore. The high statistical significance, high perceived importance, the intensive intervention, so the number of sessions they had, the role of the health educator, the number of stressors, coping skills, those are all things that we are going to focus on as our immediate kind of next steps program-wise. So this is kind of the culmination of all of this, right? So we had this year of looking at data, a year of interpreting it, and this is our proposed next step moving forward based on all of this. We're looking at a 2-tiered system for intervention. The top tier here would be exactly the same as what we're doing and what we've been doing for 15 years, where all pregnant women with a history of tobacco use will get First Breath. Brief intervention, 3 sessions, part of existing prenatal care, and delivered by you, a prenatal care provider. We know it works. The research supports it, so we're going to continue to do that. What we're proposing is this add-on. with the expanded services, which we know are really effective for low-income women. And we don't know more broadly, but we'd like to find out. And that is the intensive smoking cessation versus brief, what you do, the relapse prevention piece in the postpartum, and then looking at, within these 8 sessions, stress management and the social environment. So if she has other smokers in the home, that we're able to engage them, refer them to Quit Line, see if they're ready to make a change, provide them information and referrals as needed. We would propose the home and phone base, so non-clinical, because we know asking moms to do another appointment is probably setting up for failure. Carbon monoxide breath test. We like the hard data, but the women also really like doing the test. There was such an interesting response to them. Yeah, it was like they loved the numbers. They wanted to see it go up. We would have, boyfriend in the back of the couch like, can I do it next? I mean, it was kind of a hit. So we would like to continue to do that. We'd like to continue to do gift cards, although not as much. CMS is not footing the bill anymore, so we'll have to look at that. And then delivered by our health educators, Hattie, Felicia, Teal, the others who are certified tobacco treatment specialists. So they can really get in and get into the details and into the intensive intervention where you might not have the time or the ability to kind of go that in depth with them. Does that make sense? Okay. So we've been trying this out over the last year, as Chelsea mentioned in her intro. We've been trying to translate this out of the research world and into the real world, because as you know, that could change things. We have small grants right now to implement this in all of western Wisconsin. And we also have another grant that's covering Dane, Sauk, and Rock counties. These are smaller grants to just kind of test the waters a little bit. The other big one we have that we're going to launch probably in the next 2 weeks, I would say, maybe 3, is a research grant that we got to serve all of eastern Wisconsin. So all of you in Milwaukee and Kenosha, Waukesha, Waukesha's here somewhere. Oh, wow, they're right there. And yep, Kenosha. So we can serve the women in your areas through this research grant. And basically what we're looking at is, instead of focusing on the impact of financial incentives, we're looking at the actual intervention. And the funding is from ICTR, which is a translational research grant. So they're asking us to see, how does this work in the real world? Can we do it? And is this something that's sustainable that we can continue to do and offer statewide, which is our goal. So the other piece which I was talking about was the sustainability. Is this something that we want to continue on? What do you think about it? And that's where we are right now. Next steps. So one thing that you'll see before the end of the year is the final report of these results. There's the long version, which is like 70 pages. So if you like numbers or you are struggling with insomnia, that's your version. We'll also have the short version, which is just probably 2 or 3 pages that you can share with your colleagues, supervisors, other partners. So those will definitely get to you before the end of the year. The other thing is the overall analysis. So remember, this was just kind of one piece of this study. The main study with the Quit Line enrollees and First Breath looking at just gift cards, that analysis will be out either later this year or early next year. We'll make sure that you get that too. We're going to continue to collect all of this feedback from you, our providers, other partners in tobacco and maternal and child health. We're going to kind of collect that systematically over the next year, along with that translational research grant that we hope we can help some of your participants, hopefully that they can get enrolled in that. And we'll continue that throughout 2017. And then in 2018, we'll have formal recommendations. We'll say, this is what we found with this research. This is what our partners think, and then that will be our kind of formal recommendations moving forward. But before then, because 2018 seems like a long way away. I know it's really not, but it sounds like a long time. In the meantime, we hope to have more training materials for you, more tools that we use that we are kind of adapting that you could use in the brief intervention setting. So those will be coming down the pike in the next year or two. Teal is going to do one session for you this afternoon, so that'll be kind of your first taste, and then statewide meeting and other things. So this is not the end that you'll hear of this. But I want to end with this quote from one of our Striving to Quit participants. We asked, as part of this testimonial project, where we did videos of graduates, we asked, how do you feel now that you've quit? And she said, it's amazing to see the change in myself. That part of my life is gone. I'm just happier. And I think that is just such a great quote to end on. It's why we do what we do. It's why we do what we do. And I think it's a real privilege to be able to work with women shortly after they have their baby, to be allowed into their home. We find that really, a privilege. And also a privilege to work with all of you, that you've done this amazing work with pregnant women to get them started. So I'm going to end there. If you have questions, I'm here the rest of the day, or my email, my phone number are there, so feel free to contact me. And with that, I will pass it over to Chelsea.
Thank you.
So thank you.